Enhanced recovery after surgery, ERAS for cesarean. Barriers. Some of the barriers that we face are what we call a traditional way of thinking. In the anesthesia practice, we've done X, Y, and Z for so long that this is the only correct and acceptable way of doing it. With that closed mind, you're not thinking about evidence-based practice and what they can do for your patients. Next, what we call a buy-in, change of practice. If we can get everyone to buy in, that would be the key. But there's obstetrics, there's pharmacology, there's residents, there's surgeons. To buy in, it's hard to get everyone in at the same time. And protocols are not all for one and one for all. I think you would have to address a certain group of patients that fit a certain criteria. A diabetic patient on MAG with eclampsia would not be someone that we would want to do this on. And the last barrier is lack of data. There's not much evidence for this, so a lack of data. It's a team effort. When we come to think of things for patients, it is not just patient specific. It includes the patient, surgeon, anesthesia, the pre-admission testing staff, the perioperative staff, intraoperative staff, the post-anesthesia care unit staff, and the discharge and follow-up. So all of these, the patient, staff, and the faculty come together as a team. From the AANA, the key elements of ERAS includes patient family education, patient optimization prior to admission, minimal fasting that includes a carbohydrate beverage 2 hours before anesthesia, multimodal analgesic with appropriate use of opioids when indicated, return to normal diet and activities the day of surgery, and return home. This is all brought through from even coming to the hospital. Once you arrive at the hospital, the intra-op, the post-op, the going home, and then even on discharge. Anesthesia's main goal is prior to coming to the OR to bring everyone together. Make sure that nothing has been missed. Anesthesia is normally the hard stop, whether it's giving drugs, whether not to give drugs, whether is this the right thing that we should be doing anesthetic-wise or not. We need to make sure that everything has been completed. Anesthesia's goal intraoperative is multimodal pain management, whether that's IV Tylenol, per rectal Tylenol, Robaxin, ketamine, Toradol. All those are different methods that we can use for multimodal pain management, with opioid intrathecally being the number one. We want to also maintain euvolema. Used to, there would be 2 to 3 liters of pit bags after the C-section, but now goal is going more towards 150 milliliters. Anesthesia's goal post-operative is to control pain and to control nausea. Operative interventions. We want to meet with the surgeon and anesthesia, educate the patient on ERAS, the benefits, what to expect, and to answer all questions. We want no solids foods after 2200 if they're scheduled for a 7 a.m. start. Clear liquids are okay up to 2 hours before the surgery. We do not want them to smoke. We want to teach them how to scrub with the chlorhexidine. We'll make sure that all these ladies get typed and screened. We want to have subsequent compression devices on, and education is key. We want to make sure that they have multimodal pain management. Acetaminophen 1,000 milligrams by mouth, Celebrex 200 milligrams by mouth, and gabapentin 300 milligrams by mouth. We would like something to help with the post-op nausea and vomiting. Vicitra, Zofran, metoclopramide would be the 3 good choices. NSAID would be weight-based, and we want to make sure that they get a carbohydrate drink. Intraoperative, regional anesthesia is the key. We want to do a spinal, an epidural, or spinal and epidural with opioid, either 0.1 to 0.2 milligrams of morphine with 10 to 20 mics of fentanyl. We can also add a transverse abdominis plane block or a quadratus lumborum block to help with pain. You can use either ropivacaine or bupivacaine with or without Exparel. We want to give some vasopressors to maintain blood pressure. Neosynephrine would be the better choice over ephedrine as it causes less acidosis to baby. Euvolema, normotherma, euglycema, once again, the multimodal from acetaminophen and Toradol. Post-operative, we want to resume a normal diet as soon as possible. We want to sit up for all meals out of bed. Pain control would schedule acetaminophen, ketorolac, gabapentin, and opioids as needed. Of course, our goal is to decrease the opioids, but if they are needed, we need to aim what's best for the patient at this time. We want to get out of bed within 6 hours. We want to ambulate and make sure we have PTE prophylaxis. Turn, cough, and deep breathe. I know from a cesarean incision is what they consider nasty and major surgery, but they need to be up ambulating to help recovery. We want to remove the Foley within 6 hours, and we want to manage postpartum hemorrhages. Here is a table showing how ERAS prior, education, and post has made a difference.